Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into the podcast. I appreciate you being here. Today, I'm going to go into endometriosis. I have a lot of material to discuss, a lot of things I think that don't get discussed in endometriosis, and I think things that would be very helpful. Before I start, if you wouldn't mind, just kind of roll down there a little bit. You'll see there's a button you can press that says subscribe. Please subscribe. If you like it, share it. All right. With that said, let's get started. You know, I was thinking about endometriosis regarding care and how we treat it in my practice and what my experience has been with it. Endometriosis affects so many women, you know, up to 10% of the population. And it's a debilitating condition for many. And there's a lot of cases of silent endometriosis. It's a big issue. And I wanted to make a series of episodes for you that are helpful. By no means is this meant to be exhaustive. I want you to know that. And I want you to know, I know when I go into a room with a patient, no doctor should ever enter the room with the idea that they have all the answers. You always must enter the room with a sense of curiosity and a sense of willingness to challenge everything we thought. We must do that to be effective and helpful. It truly is. It's the most important thing I think a physician can do is have that open mind, because the arrogance of practicing medicine is that I know what I'm doing. I've been doing this long enough. I have all the answers, until you find the one case where you don't. And that's life. So these episodes are meant to be helpful, not exhaustive, helpful. And while I am a physician in the state of Arizona, I am not your physician. I do want you to have a healthy relationship with your doctor. To the degree that these episodes can help you with that, with giving you language that you can use when you speak with them, questions you can ask, you know, ways to help promote that relationship to be more healthy. Because I know many of us don't have healthy relationships with our care providers. A lot of times, I mean, how can it be? You're in the room for 9 minutes, maybe. Or a lot of times they just dismiss you, like with endometriosis. Endometriosis is a condition where the endometrial tissue, or the lining of the uterus. So let me back up and talk about the hormones that go into play and the cycle and how this occurs. And then from there, I'll branch out a little bit more. In a normal cycle with a woman, at the beginning of the cycle, the body recruits several follicles from the ovaries on both sides. And those follicles start to release estrogen. And estrogen is important because it's associated with getting your body ready to become pregnant and then help maintain the pregnancy. It's a part of the whole equation. But estrogen is also responsible for so many other aspects of your health, like bone density, brain chemistry, cholesterol. I mean, the list is very long. So estrogen has a lot of roles other than fertility. In the first 2 weeks, estrogen is dominant. It stimulates all the tissue that you have associated with fertility: breasts, uterus, cervix, ovaries. It does its job. And then around day 12, you'll hit a crescendo, a very high level of estrogen, and that stimulates the body to ovulate. Okay, and that's when the ovaries will ovulate. Now, all those follicles that were secreting estrogen, they now turn into something called corpus luteum, and that releases progesterone instead. A little estrogen still, but progesterone becomes dominant. Progesterone is the main important player at that point. Progesterone goes back to that tissue that was being stimulated by estrogen, and progesterone calms it down. It promotes blood flow to the line of the uterus. It plays a role in lobulizing breast tissue. It modulates the impact of estrogen on your body fat, your adipocytes. It stops the tissue from being over-recruited. Progesterone is so important when it comes to balancing the positive growth effects of estrogen. It is such an important part of you. The other thing that progesterone does is it crosses the blood-brain barrier. This is important. I'll key into it later in this episode and a lot more in the next episode and the episode after. Progesterone crosses the blood-brain barrier, and it converts to something called allopregnanolone. Allopregnanolone is a huge part of brain chemistry. It plays a role with sleep, plays a role with anxiety, plays a role with depression. You need progesterone to have a healthy brain chemistry. Women, this is very important. Your brains are geared towards more needing progesterone for proper brain chemistry. With that said, men have progesterone too, just less amounts. We rely more on our androgens, such as testosterone. That plays a role with that part of our brain. But with women, it really is important to acknowledge and understand the essential the essential aspect of just healthy brain chemistry that progesterone plays. And I know I've said this before in many episodes, but it needs to be repeated. It always can be repeated. It's so important. So progesterone and estrogen, that's cycling throughout the month. That's your cycle, because progesterone will go up, it matures the tissue. If you don't have egg implanting, you don't have that, you didn't conceive that month, estrogen and progesterone both drop down, menstruation, start the cycle again. That is a normal cycle. What is endometriosis? Endometriosis is when that lining of the uterus, that's supposed to be in the uterine lining, it grows during the first 2 weeks from estrogen stimulation. It finds itself no longer. Endometriosis is when that lining, there are pieces of that lining that are found outside the uterus. They're found in different areas of the body. Generally, it's in the retroperitoneal. It's a peritoneal cavity that's superficial. Sometimes you'll see it in other areas of the body, which is a little bit more deep endometriosis. Then you'll also have cases where it's around the actual follicle, and you see that as well as being concerned in the ovaries. Then we have to think about this for a minute. You have this tissue in a different part of your body than the lining of the uterus. It's going to now grow whenever estrogen is stimulating it. So now you're going to have tissue around your ovaries, and your ovaries that's around in that area that's going to be growing with the estrogen dominance. So that growth is going to create more pressure. It creates pain. There's also a lot of inflammatory aspects to that happening in a different part of your body. Wherever you're going to be growing that tissue, you're going to have increased levels of pain. So when women present to clinic with endometriosis, that's active and flaring, there's pain with their cycle. There's pain in ovulation sometimes. There's pain with intimacy or after intimacy. There's dysfunctional uterine bleeding or heavier bleeding. Fertility is a concern. But the thing I want to point out here is that pain is a big thing. And women, and I remember this when I was young. I remember I was younger when I was maybe in late teens when I first started hearing about this. And I know I'm a guy, and I don't know why, I don't know, but I remember it very clearly. Women having endometriosis, and I remember that. Even then, looking back, I know women were gaslit. I know the term's used a lot in popular culture, but you got to use it when it's appropriate, right? So this is what it was. Go to your doctor and you have pain and they dismiss you. And we know this to be true. It's been like this for forever. It's getting better, but you'd be dismissed because of the pain you have. See, this is what it means to be a woman, because the doctor in front of you never had this kind of pain. So they have no understanding what it's like. I don't know what it's like. I know that. But I also know that that doesn't give me the right to assume what it is based upon my own personal perceptions or what my needs are. Because a lot of times the doctor's like, well, I don't really need to deal with this. This is pain. I don't see anything I can measure. And that's what you'd see. And a lot of times back, in the 90s, 80s, and even in modern days, but I'm just saying back in the day, there was no real lab work to understand it. And imaging wasn't really very advanced. And there was no money being spent in women's health. There still is very little, but still is even worse back then, more barbaric. And what they would do, the standard of care would be just like, they would treat it like it was like PMS or, something like that. They'd be like, well, we'll just give you contraceptives. And that's what they would do. Over time, then they started doing more surgical procedures, which were also not always effective, birth control and surgery. And that was the mainstay of care. And to be honest with you, it hasn't changed. It still is. Those are the mainstays of care. And those of you with endometriosis know that it's not the best therapies. It doesn't always work. Sometimes it doesn't. Some of you, it's worked for you. That's awesome. I'm so happy that this has balance for you. But most women, it doesn't. Then the question becomes, why? Why didn't that work? And also, what can we do that's better for you? So how I want to be helpful is to give you some ideas on how I approach it and how I see it. And I'm not just going to do that from just, when you have endometriosis, take this herb. When you have endometriosis, take this vitamin. I'm going to be way more scientific with you because that's what you need. I don't ever want to recommend something to you that I cannot show you it was effective. That's, in my mind, good medicine. We always want to be evidence-based. And I know that's another word that gets thrown around. But let me tell you what that really, really, really means in the world. Evidence-based means I use evidence to understand what you have. I use evidence to verify my diagnosis. I use evidence to verify what I did worked. It's not enough for me to say, I think you have this, here's your pill, call me in the morning, or if you have any more problems. And meanwhile, I don't take the call, which is what happens to a lot of you, So no, I really want you to know how I treat it, what the science is behind it. I'll explain it in a clear way. And then I want to be really good about how you can apply this with your physician, how you can approach your physician with it. So things I want to drill down on here. So the things I want to drill down into with this series that we're doing on endometriosis, I want to talk about the balance of estrogen and progesterone, because that's the center point of that. That is the most important component of this to discuss. That is everything in here. And if you get anything from this little series we're about to do on endometriosis, is that estrogen progesterone ratio and the estrogen progesterone interplay needs to be brought to balance. That's a very important part of treating endometriosis. Very important. Other things we want to discuss is going to be inflammation. Inflammation is a key component of endometriosis as well. It's an inflammatory condition. And the inflammatory condition is rooted in the relationship between estrogen and progesterone. But still, while we're balancing the estrogen and progesterone, we still need to be focused on inflammation. If a person's hormones are out of balance and they're living a very inflammatory lifestyle, they're eating a very inflammatory diet, which I'll explain a little bit more in a bit, that combination of the two, you're going to have the highest incidence of endometriosis. Truth. What if I got their hormones balanced out? Would that be enough? I argue no, because I've done that. It doesn't always work very well. You really must go after the inflammation in the person's lifestyle. So you really need to approach the lifestyle from how can we reduce inflammation? How can we improve the way their body navigates through an inflammatory process? So that's the other thing I want to go into. And the third component, I'm going to talk a little bit about, not as much, but a little bit about endocrine disrupting compounds. Endocrine disrupting compounds have an impact on your endocrine system in the sense that they inhibit the normal flow of progesterone. They inhibit progesterone. They mimic estrogen. And when they mimic estrogen, these chemicals in the environment, they bind to that receptor in such a unique way. It just modulates it where it's like not just estrogen anymore. It's like it's a synthetic. It's overactive on the receptor. And it really creates this disruption in people that long-term is a problem. So I'm going to go through those three big areas to drill down into. So that's my introduction in endometriosis. That's going to be how I'm going to approach it with you guys. My next episode, we're going to go into a little bit more about that estrogen dominance. What is estrogen dominance? And spoiler alert, when I talk about estrogen dominance, I'm not going to vilify estrogen. Estrogen is neither good nor bad. Estrogen is estrogen. That's it. It's beautiful. It's wonderful. It's a part of you. It's only when it's out of balance. We're going to talk about the causes of low progesterone. We're also going to discuss a little bit more specifics on endocrine disrupting compounds and inflammation. Then the third video, we're going to talk about how to lab around this and how to treat around this. So thank you so much for tuning into the podcast. I truly appreciate it. Like, share, and subscribe. And as always, your comments mean everything to us. We really do read through them. It really does help us drive the content. We're doing this endometriosis series based upon your requests. And I want to be of service with this podcast. My goal is to always be of service to you. So the best way to be of service is to know what you need and what you want. Not for me to guess what it is or think about it is, but really listen to you. So your comments are heard and we do care. All right. Thank you so much for tuning in. I'll see you in the next episode.